Very good morning to all of you, and thanks, Dr. Chitra. It's a privilege to be on this course, and one of my favorite subjects to talk on. So, uh, as time goes, we all realize that refractive surgery has become, of course, so exciting. But of course, the indications and the case selection criteria also keep changing with time. So it's always good to have these changes happen. So the idea was today to just put forth a few situations and then have our expert panels comments on that. And please feel free to chip in as well. If of course we'll stick to our time, but so I have no financial interest. Now let's start with a situation where there is this 21-year-old male who's walked in as a LASIK candidate. He has a correction of -6 diopters in the right eye with 2.25 at 30 degrees in the right eye astigmatism, and left eye 4.5 sphere with 1.75 at 170. Improves to just about 6/6 partial. These are the pentacam anterior curvature reports, and if you notice that there is this slightly suspicious steepening, but it's not enough to flag it. This is the further data for this patient. The right eye central pachymetry is just 459, and the left eye is 453. And if you'll notice here that the chamber depth from the endothelium is 3.28 and 3.23, which is a pretty good AC depth. Now, look at the posterior float and the pachymetry profile of this patient. Of course, you'll notice that pachymetry is small, and the thinnest location is almost the same as what it is at the pupil center. And if you look at the posterior elevation, you'll realize that it's not typically a keratoconus situation, but then we have a high correction of almost 6.5 diopters. So let me just take you back to the previous slide where we have the data. Now this is what we need to correct. So what should we offer this patient? Now what this brings out is 2 or 3 important issues. What should be the thinnest pachymetry on which you will be willing to perform a laser procedure of any kind, be it surface ablation or a flap or anything, and what might be the correction, even if you were going for a surface treatment, at what level will you cut off, and what is the minimum residual bed you'll want to leave. So with 2 stalwarts sitting here, and I was hoping that would you like to invite, Dr. Chitra, who are the other instructors on our course, and can we also have them on the panel if they're here? No. Okay, so as they come, we'll probably have them as well chip in. But Dr. Chitra, I think I throw this on to you, and then just to initiate a discussion that what would you do for this patient? Would you treat with a surface ablation? Would you go with that? Or would you, looking at the topography and the amount of correction and the pachymetry, what would be your first choice of treatment and why? What would you opt for then? Are you talking about ICL?
ICL only.
Okay, so you would go with an ICL. Kumar, would you do something different?
Your ACD from the endothelium was 329?
3.2, yes.
Yeah, there is no option except a toric ICL.
Right. Now, just for the sake of, even I would probably do an ICL for this patient, especially with that astigmatism and a large enough correction. Now, just for the sake of being clear and giving the message, what would be your cutoff for a surface ablation? What's the thinnest cornea you would do a surface ablation on?
No, I wouldn't mind doing even up to 455, but if it is 455, I would not do more than 0.5 or 0.75.
No, but what is your residual bed after ablation? What's the bed that you would like to leave?
I would definitely like to have a 300 plus residual bed.
So here you would actually be able to do that. If you had 450 cornea and you did a 50 micron epithelium scrape, you would still have 100 microns for ablation, right?
Yes, but there is more regression as you go thinner and thinner. So better to place it.
So, I think the dictum today, and in fact there's been a lot of debate going on just over the last 2-3 days in the ASCRS forum on this, that now the cutoff for doing a surface ablation in many hands, people who are experienced with laser corrections, is now down to 450 if you have an absolutely healthy cornea, which means that no flags, no red signs. You can actually do a surface ablation on a patient which is a minimum thickness of 450, but do a limited ablation and try to leave behind a bed of at least 300 to 350 for a surface ablation. So depending on how experienced you feel, but this patient was basically to get this message across. Now, I think I just realized here that one of my slides is mixed up, so let me just skip that one. I'll go to this third case. So there is this 23-year-old male patient, and he has a -14 in the right eye with a 1.25 cylinder. Second, high myope but stable, -13.5 in the left eye with a 0.5 cylinder, and with the rule astigmatism. And topography is really unremarkable. If you look at the pachymetry, we have very good thick cornea, 600 plus microns on both sides. and the AC depth here is compromised. So we have an AC depth which is just about 2.75. So here the dilemma is that you don't have, the correction requires you to put an ICL, but you don't have enough room to put an ICL here. Dr. Chitra, would you put an ICL in this? Are you experienced with thinner corneas? What is your criteria for example, here we have a 600 microns cornea. So when you say -10, what do you really mean as far as the ablation depth is concerned? What's your cutoff? I mean, I think that's what will decide how much you want to ablate, right?
Largely, I would not like to cross 130 microns.
130 microns. So, I think that's very important message to put across, that if you are ablating, please try not to exceed 125 to 130. Dr. Ramamurthy, what cutoff do you use, like for total depth of ablation in a given patient? Even if you have like a 600 cornea here, what is the maximum ablation depth you'll do, and would you choose an optical zone which is like 5.5 today?
Actually, we stick to a 6 millimeter, neither go beyond nor go down. It's always 6 millimeters. In our machine, it consumes about 11 microns per diopter, whether it's a sphere or a cylinder. So it's -6 with -4 means it's 10 diopters. For me, again, the cutoff is about 10 to 11 diopters. And usually I do not go beyond 130 to 140 microns, irrespective of the corneal thickness.
Kumar, you use a different machine, so what's your cutoff, and how much your machine consumes per diopter?
It's about 12 or 13.
12 microns.
Yeah, but I'm a little confused. If you have excellent thickness cornea, and if you do a flap of 90 microns, let's presume that, you're still at a good safety level.
I know. So theoretically speaking, Kumar, you have 200 microns available for ablation, right? Which means you could actually go up till 20 diopters. I mean, but that's all theoretical. So practically, how much would be the maximum correction? That's exactly why this case has been put up, because can we go around ablating 15, 16 diopters? I mean,
no, I feel the quality of the vision drops down when you make the cornea more oblate. So it's largely safest not to go beyond 10 or 11.
So anybody? Okay, let's go back. I'll just go to that previous slide. The K values here are 45 on both sides, right? So exactly. Again, Dr. Ramamurthy, for K values, suppose you had to do 11 or 12 diopters maximum full ablation, right? And what would be your decision if you had a patient with K values of say 42? Would you change your?
I don't want to leave the corneas less than 35 diopters flatter or beyond 50 diopters steeper. And exactly this thickness and K values alone do not. If we start off with a 41 diopter cornea and say a 500 microns thickness, you might leave it behind with, drop it down to 35 and bring it to 450. But it's not the same as bringing down a 600 micron cornea to 450. Because the amount of spherical aberration that you induce, even if you're using an aspheric profile, is going to be extreme. So it's not just the numbers alone, but you need to look at what you're starting with and where you are ending up at.
So several considerations there. One is that maximum depth of ablation, you have to keep a mind on that. What optical zone? So I also don't go down below 6 anymore. Sometimes with FCAT, I'll go down to 5.9 or 5.8 in pupils who are like really small pupils. But the second is the keratometries, and you have to watch out if you're doing a hyperope. So we have another hyperope example coming up. Let's just move on. And so this was the last patient. Now, this is a 41-year-old lady. Right eye has a high correction of 13.25 with 1.25 cylinder, and the left eye has just about 2.5 with 1.5 cylinder at 100 degrees. So right eye is basically anisometropic and a little bit of amblyopia. The topographies are unremarkable. There's a 550 cornea on the right side, 519 on the left side. So God has given her a thicker cornea on the side where the power is more. For some reason, she's lucky. What would you decide to do? AC depth is adequate for an ICL, so it's a 2.91 in the right, but in the left we don't have enough AC depth for comfortably putting in an ICL. So you have two eyes which are different in several ways. How would you manage this? So let's start with Dr. Ramamurthy first. Okay. So Kumar.
You can think of LASIK in one and ICL in the other.
So you would do LASIK in the right eye or ICL in the right eye?
Where your depth was higher,
okay, so
290.
So in the eye which has a 13 diopters of correction, you would choose an ICL. Now also you have to see that this patient is already 41. So, typically what's your cutoff for ICL? Right. So considerations here would be she's already had anisometropia and a very high myopia in one eye. She's probably not even using the full correction in that eye. What we could do is we could do a laser correction on the left to achieve a full correction. In the right, we could actually plan for a monovision lever, maybe 1.5 diopters or so, or even 2 diopters myopic. And that would still give this patient a very, very good high quality. I mean, she would be able to utilize binocularity to a larger extent than what she has been doing now. So you have to actually, now if this age was different, see, if we were dealing with somebody who was maybe 25, we would have started immediately thinking of putting an ICL or something and trying to give a full correction. So several factors come into play when you have to go. I'll quickly go on to my last case because I have only limited time. So let's see, I'll go on to the next patient, one moment. I think I would probably go on to, I had several, but okay. So there is this gentleman, 25 years old, athlete by profession, high hyperope, uses glasses only occasionally because he doesn't enjoy wearing glasses, and in some areas there's a social stigma even for boys to be wearing glasses. Cycloplegic refraction shows high hyperopia of plus 7.5 in the right eye, 6.75 in the left eye. Keratometry is 41.5, 42 in both eyes, in similar keratometries in both eyes. Currently using glasses which are 4.5 in the right eye plus 4 in the left eye. So even though he has cycloplegic refraction of almost 7.5, but he's only using glasses which are 4.5, the keratometry is more or less suitable for doing a fair amount of correction. Now, pachymetry is of course healthy. AC depth is small, it's only 2.65 as you would expect with a high hyperope.